Welcome back, fellow psychiatrists and psychiatry wannabes. By wannabe, that's not supposed to be disparaging. Maybe you're a medical student, right? You want to be a psychiatrist. It's a great field. So today, I do these in one take. We're just going to move with it. We're going to work on the treatment of anxiety disorders, and it's going to be first line drugs. And by drugs, for this, I mean chronic drugs, things that are scheduled. You give every day until you stop. Not as needed, not I feel anxious, give me something kind of thing. These are first line drugs, and for me, that means the first drug you try, the second drug you try, the third drug you try, and then you're like, okay, let me go to drugs that are probably worse. And I will kind of explain why these are what I consider the first line drugs. If you just go by RCTs and FDA approval, all the SSRIs and two of the SNRIs and a TCA and some other drugs all have randomized controlled trials showing they work. And there's not going to be a huge efficacy difference between these drugs. FDA is in orange, and if you see escitalopram, paroxetine, and duloxetine work for generalized anxiety disorder and panic disorder for FDA approval. So if you just want to do FDA approval and RCT evidence, and it's whether they're worried all the time or they freak out randomly, you can always go escitalopram, paroxetine, venlafaxine. Those drugs, and I would do it in that order. So let's talk about the SSRI side effects and things, just so you're kind of back on page and get a refresher. Nope, that's not the one. Pharmacokinetics, there we go. The things that make them different on pharmacokinetics to always pay attention to is that paroxetine and fluvoxamine have short half-lives. This is your chance to use fluvoxamine. It doesn't work for MDD, but it does work for anxiety. But it has a 15-hour half-life. That's horrible. It's actually it's an older drug, that's why. And so it takes a BID dosing, so I would never use that as a first-line choice. But we'll consider it for second line. Paroxetine is also short at 21 hours, and then everything else is longer, with fluoxetine being the weirdo drug, which is like the opposite end of fluvoxamine, where it just self-tapers. It takes a week to get up, and a week to get out, kind of thing, a couple weeks. If we look at side effects, remember, if you stop any of these drugs other than fluoxetine, you get withdrawal effects. Weight gain is stated. I wouldn't get all caught up in it. It says fluoxetine, sertraline. They've done some studies where they've gained weight and they put it as an absolute number. So let's say 6 pounds. But really, it's often given for depression. And if you're depressed or anxious, some people have reduced appetite, right? They just regain their appetite. So some portion of that's not real. In general, you could consider fluoxetine, sertraline as the worst offenders in that situation, if that's a big issue for you. Sexual dysfunction is a big issue between all of them. We'll just compare it this way. So we'll see the right-sided column. Everything is sexual dysfunction. Whoops, sorry, I stopped my timer on accident. And paroxetine, though, is super significant there. So if you want to cause a person to have sexual side effects, it's going to happen with it. But it's also really good for generalized anxiety and panic disorders, so still worth a shot. It's supposed to, sticking with paroxetine for a second, it's supposed to have the anticholinergic orthostatic hypotension angle. There's a lot of studies using it, looking at it for comparisons in geriatrics and against other drugs. And they don't really drop out at a higher rate usually. A lot of times, you can look at the side effect profile as being similar to sertraline a lot, like as far as people are dropping out or it's really an issue with geriatric. I don't think it's reasonable that we always knock it out so quickly. I still do, but it definitely, if you're really treating anxiety and you want to do a good job, probably should be a first line choice for you, or really strongly considered, A tier if it didn't make it to the S tier, for like video game references. So citalopram was on that list, or escitalopram was, where citalopram is for generalized anxiety disorder treatment and panic disorder. Citalopram has the known dose-dependent QTC prolongation, with QTC prolongation meaning it calls torsades de pointes, which means cardiac arrest death. So that has to be paid attention to. Fluoxetine and sertraline are quote activating, so they're not on my list as first line. When I put quote activating, it's because I looked this up the other day, and these are part of those terms that I just don't like in psychiatry. They don't mean anything, or it's like what they call a suitcase term, where they just shove a bunch of information in it, and you're like, yeah, this makes me feel good in this way, or this kind of idea, this ball of thoughts. It's not actually a very accurate, specific term. It'll refer to changes in behavior, emotion, or cognition, and they can mean increased energy, hyperactivity, restlessness, akathisia, irritability, nervousness, excitability, lability, insomnia, disinhibition. Do you really consider akathisia the same as insomnia, or as the same as disinhibition? I don't know what to do with that. So I think this is just part of that situation where maybe you feel less tired or something, and as long as you prep the patient realistically and just say some people feel a little more energetic and good mood, if it causes you, if you feel like it makes it hard to sleep, just take it earlier in the day, something like that. Just a little bit of patient education, and you'll probably get yourself out of trouble with it. And you can always start low, go slow, but let's see, where is it? There we go. But for the actual just treatment process, I would say for paroxetine, escitalopram, citalopram should be your first lines. Escitalopram, citalopram, I mentally think of them as the same drug. Basically, you have citalopram, then the drug company waits, and they cleverly get rid of the one of the enantiomers. Now it's the S version instead of the levo. That's the active component, so it takes half the dose, so apparently it's 50-50, right? They're easy drugs to dose. Like citalopram is a 20-40 drug. It's a two-step drug, just like escitalopram. It's a 10-20 two-step drug. If they're very frail, you go half, 5 or 10 milligrams. The thing is, citalopram and not escitalopram has that prolonged QTC. So person with cardiac problems should not get that drug. They both should be good for geriatrics nonetheless. That's just because the polypharmacy, drug-drug interaction, that kind of thing, is not there. It doesn't really have difficulties. Paroxetine has a lot more steps involved, so it's not as good of a drug, in my opinion. Anytime you have to change a drug 5 times, I just think that's garbage. If you're super anxious and miserable, would you rather wait 3 months or a month and a half to get better, right? Like if you're working trying to get to a therapeutic dose forever, then it's probably not as good. Paroxetine is a 2-dose drug. It's an IRR2 formulation drug. It's immediate release and controlled release. I have heard exact opposite things on this, so I don't know what to make of it. So, because both logics work, which means psychiatrists don't know what they're talking about because different drugs do it differently. I've heard some doctors say give immediate release. That way, if it has side effects, it's out of their system and you move on. Some people say controlled release because it has a slower on and off. Neither of those tell you if it's the peak dose that matter, and if it's the area under the curve and how high you are, then neither of those may be relevant. It might just be how much is in your blood. So the logic is not good pharmacy, pharmacokinetics, pharmacodynamics logic. Typically, I would give immediate release. You start at 20 milligrams. It can be a little sedating. You give it at night. You start 20 milligrams, and it can go 20 up to 60. If you want to be cautious with the patient, you go 10 milligram increments. It could be done every week, right? It had a half-life just under 1 day, 21 hours, mean for the population they studied. So that's fine. You can go 20, 30, 40, 50, 60 very quickly if you just do it every week as they tolerate it, or at least go 20 to 40 and then 40 to 60 and let them do the intervals. Sexual dysfunction is a problem. So if we go to the SNRIs, so it's venlafaxine, and then duloxetine are the 2 drugs that we care about right now. So they do have metabolism interactions with like the cytochrome P450 system, with like the 3A4 being a big one and 2D6 with venlafaxine, so you get that drug-drug interaction, which means I wouldn't pick it before the SSRIs. And then the duloxetine also does 2D6, which can be an issue. 1A2 less of an issue. Venlafaxine, is not, so these drugs are not the same, right? We think of SNRIs and SSRIs and we just throw them in a group, but venlafaxine is truly an SSRI that becomes an SNRI. It has a 30 to 1 binding capacity towards the serotonin receptor. So basically just sequentially floods, maxes out serotonin receptors, and then it goes to the norepinephrine. The duloxetine is 10 to 1, so that's actually at that ratio. It'll mostly do SSRI, but it'll start picking up the norepinephrine receptors more quickly. So they have kind of the same side effects as SSRIs, plus you get to like a little bit of norepinephrine kind of thing. So it's like tachycardia, feeling their palpitations. They say give headaches, but then it can also be used for headaches, so it gets weird. Nausea, dizziness, it's supposed to be a little bit easier on the body with the duloxetine per some people. Desvenlafaxine we're not using again for this. It doesn't work for anxiety. So if we look at those drugs, let's see. Actually, I need to move my picture first. Okay. These drugs I also don't like because they do so many steps to treat with them. I think if you can always do a drug in 1 or 2 doses and get to them to the therapeutic dose, see if it works, you're always better off, because again, you often have to use 2 drugs to see if it works, and it might take 1 or 2 drugs before it's the right one, even at that point. So you could go up through 3 or 4 drugs pretty reasonably. Venlafaxine and duloxetine have terrible withdrawal effects. I particularly don't like venlafaxine because of that. It doesn't matter if it's XR or whatever, none of that matters. When a person's at like 225 milligrams, when you try to get them off, it might take 2 or 3 months to get them off because of severe like headaches, feeling like they have flu symptoms, all sorts of things. So venlafaxine is a drug you start at 75 milligrams, and then you have to have a separate, different dosing. It's 37.5, and then you stair step up to 225. If they're frail, you can go down. You can do just those 37.5 milligram increments. A good patient it actually can be used to treat migraine, fatigue, neuropathy, like like diabetic polyneuropathy, lower back pain, where you have nerve pain. So, and it says they're a bad patient if they're anxious, but it's actually an FDA-approved and randomized controlled trial showing that it works. So this is where like the evidence in psychiatry just gets to be garbage or weird so often. Again, just tell them that about the side effects so that they're not a surprise because they're already anxious and worrying. You're going to make it worse. Duloxetine is easier. It's a 30-60 milligram drug, so 2-step. And it also picks up fibromyalgia, which means for like IBS and kind of those other worry, stress-related somatic symptom disorders that it can help. But duloxetine, you've got to follow your AST/ALTs, your liver functions, and your CMP, because there are case studies with hepatic failure. So that's not trivial. You should pay attention to that. What else do I want to say? I think that's good for this. So the next video, we're going to start working on second-line drugs that you're likely to consider. Some of them are still SSRIs, SNRIs. It's just they weren't put in first line because of the side effect profile. Let me scroll and do this for you. And other ones are just other classes of medications to try. So it's been mostly True Psychiatry with Dr. Mellon. Have a good day.